Good evening. Okay, and welcome to our first webinar discussion. So, and this is our first webinar prepared by the Blue Health Medical Consultancy. And my name is Dr. Nathan Mulubrhan. I'm an assistant professor of emergency medicine and critical care, and CPD director of Blue Health Medical Consultancy, and I'm an author of a book entitled የቅድመ ሕክምና እርዳታ, which is again translated to Oromifa and Harari language. So today we are going to discuss about acute heart failure, and and this is the today's presentation outline. So we'll see the introductory of the definition of heart failure and the epidemiological aspects, and some of the pathophysiology, the precipitating factors, classification, diagnostic approach, management of heart failure. And according to the American College of Cardiology, heart failure is defined as it's a complex clinical syndrome that results from structural or functional impairment of the ventricular filling or rejection of blood, which in turn leads to the cardinal clinical symptoms of like dyspnea, fatigue, and signs of heart failure like edema and rails. So acute heart failure, when we see the definition of acute heart failure, it is a clinical syndrome of new or worsening of sign and symptom of heart failure, which often leads to hospitalization or emergency department visit. And it covers a wide spectrum of illness. So it ranges from as simple as gradual increment in leg swelling, shortness of breath, to its severe form, which is pulmonary edema and cardiogenic shock. So about 70% of patients with acute heart failure are these decompensated heart failure patients, or already known cardiac heart failure patient that presented with acute exacerbation, whereas 15 to 20% of the patient are heart failure, which we call de novo heart failure, or first-time presenters, and about 5% of the patient admitted with acute heart failure are due to this advanced heart failure, or what we call stage D heart failure. And when we see the epidemiological aspect, acute decompensated heart failure continues to rise in prevalence, and it is one of the substantially huge number in mortality and morbidity, and it is one of the leading cause of hospitalization in geriatric patient, or those patients with above 65 years of age. And when we see the readmission rate, it is as high as 35% at 60 days, and majority of the hospitalization, the cost due to this heart failure is due to hospitalization, like due to medications and other hospitalization costs. And about 50% of the patients are readmitted for the management of heart failure or acute heart failure within 6 months, and 5% have the like intra-hospital mortality, and 20% have 1 year mortality. And when we see the combined incidence of patients with heart failure, they have the combined incidence of cardiovascular heart failure, myocardial infarction, stroke, and sudden death. All this in combined about 50% combined incidence. So when we see the pathophysiology, usually heart failure starts with the index event. So this index event, it could be a myocardial infarction, or like external demand like anemia or thyrotoxicosis, or any valvular illness. So this the index event. Once the index event starts, it will lead to the damage to the heart muscle, and again this leads to loss of the cardiac myocytes, and the ones that, as you know, these cardiac myocytes are the contractility unit of the cardiac cells. So in general, the heart will lose this contractile ability. So this index event, once the index event has started to occur, the body tries to compensate, and these compensatory mechanisms like the activation of the RAS system, which leads to the production of renin, and renin will activate again the angiotensinogen. Angiotensinogen will activate the angiotensin 1, and subsequently in the lungs it will convert to angiotensinogen 2. And this angiotensinogen, it is a potent like vasoconstrictor, and also it will activate the suprarenal glands, and aldosterone production will be increased, and water and sodium retention will occur, and both the preload and afterload will be increased due to this the activation of RAS system. And again, this have additional burden on the cardiac workload, and this the compensatory mechanism by itself will have additional burden on the already damaged cardiac like heart muscles, or the already compromised cardiac output. These compensatory mechanisms will have additional burden, and the other compensatory mechanisms are the sympathetic nervous system activation. So this sympathetic nervous system again will release the potent what we call norepinephrine and other endogenous catecholamines like epinephrine. So they have a potent vasoconstriction effect, and that will lead to the increased in the afterload, and afterload, and that after increment in afterload will again have extra burden on the cardiac workload. So all these the compensatory mechanisms like gradually will have what we call cardiac remodeling effects, and that again will lead to this vicious cycle of the cardiac heart failure. So basically this is what we call the pathophysiology of heart failure. So mainly the clinical effects, as I have already said, the sodium and water retention, and increased in systemic vascular resistance, and these two will have like significant impacts on the preload and afterload increment. So when we see the causes and the precipitant factors, when we say causes, as you know, they are primary conditions, or what we already as index event. So it could be coronary artery disease, like myocardial infarction, or other like ventricular septal rupture and acute valvular syndromes. Like it could be mitral regurgitation, aortic regurgitation, or any other valvular dysfunction, and other like cardiomyopathies, myocarditis, or poorly controlled hypertension. These all can lead to the index event. And when we see the precipitating factors, like you can like memorize the heart failed acronym. So different precipitating factors like dietary conditions, like increment in salt intake, like myocardial infarction, arrhythmias. The most common precipitant is drug discontinuation, infection, anemias, medications like non-steroidal anti-inflammatory drugs, and other medications like calcium channel blockers, beta blockers, and alcohol consumption. Pregnancy can lead to like this, that can precipitate the already compromised or this chronic state of heart failure. They can precipitate to the acute decompensated heart failure state. So when we see the classification, we have different classification of heart failure, especially in the emergency department. We use this six classification of heart failure. This is just a phenotype kind of classification, and it's mainly used for investigation and for the initial stabilization and management purpose. So the first one is the hypertensive acute heart failure, and this kind of patient, they have the sign symptom of acute heart failure with relatively preserved left ventricular function, or their ejection fraction is it's kind of above like 50, and they have the systolic blood pressure greater than 140, and typically they have on chest X-ray they have pulmonary edema, and onset of this hypertensive acute heart failure is usually acute onset. They have acute onset, and the other is pulmonary edema. The second classification of second group of patients are pulmonary edema, and this kind of patient they have respiratory distress, rails on chest auscultation, and they have reduced oxygen saturation from the baseline, and so these are kind of pulmonary edema, or what you know as pulmonary edema patients. And the third group is cardiogenic shock. So they have low cardiac output state with low tissue perfusion. So they have this systolic blood pressure. Usually it's less than 90 millimeter mercury, and they have sign symptom of this shock. And the other is acute on chronic or decompensated heart failure. So they have sign symptom of acute heart failure, but it's mild to moderate, and they do not meet the criteria of either the hypertensive acute heart failure, pulmonary edema, or cardiogenic shock. They don't meet the criteria for the above three um, groups. And the fifth one is high output heart failure, and usually it's just due to the anemic or thyrotoxicosis or pregnancy kind of heart failure. And last one is right heart failure, and this kind of patient have low output syndrome, and mainly usually due to the right ventricular strains. It could be like pulmonary embolism, or a right side infraction, or is anything that will affect the right side of the heart. Or it could be like other lung conditions like COPD, and asthmatic patient they will present with this right heart failure. So in general, this is the acute heart failure classification that we use in the emergency department. The other classification is depending on whether the patient have past history of heart failure or not. So as we have already said, we can classify it as into two, which is de novo acute heart failure, which is only about 25 to 50% of the patient will be categorized in this group, and the other is acute decompensated chronic heart failure, which is majority of the heart failure patient are in this category. And the other classification is based on the patient blood pressure status. So we can classify it into three. The first one is hypertensive acute heart failure, where systolic blood pressure is above 140. And as you can see, 50% or more of acute heart failure cases are categorized in this group. Like mind you, this is just for acute heart failure, not all heart failure patients. And most likely it's like geriatric patient and female are categorized in this hypertensive acute heart failure group, and they have abrupt onset of symptoms. Usually they present with this pulmonary congestion and this pulmonary edema, and have hospital mortality of around 1.7 to 2.5% of in hospital mortality, and compared to the other group, they have lower mortality. And second is normotensive acute heart failure, and they have systolic pressure ranges from 90 to 140, and represents about 40% or more cases of acute heart failure are in this normotensive acute heart failure group. And usually these symptoms develop usually in gradual onset and involves significant systemic congestion, unlike that of hypertensive acute heart failure patient, where they have more on the pulmonary circulation will be congested. Here the systemic circulation will be congested, and they have around 8 to 10% of hospital mortality. And the last one is patients with hypotensive acute heart failure. So this group of patients, they have systolic blood pressure less than 90, and almost less than 8% of the categories are in this hypotensive acute heart failure group, and they have more poor prognostic than the comparing from the normotensive and hypertensive group, they have 50% to 30% mortality, and usually they present with this cardiogenic shock. They present with cardiogenic shock. And the other classification, we can use this wet, dry, and cold, warm by seeing the patient hemodynamic condition, signs of low cardiac output, and peripheral hypoperfusion status. By seeing all these parameters, we can classify patients into these 4 groups, which is warm and dry. When we say warm and dry, the patient is well perfused and he is without congestion. So usually this kind of patients are indirectly they're hypertensive acute heart failure patient, and the other is warm and wet. So this is well perfused but congested kind of patients. And third is cold and dry. So this hypoperfused and without congestion. And the other is, so this you can say these are cardiogenic shock patients. And the fourth one is cold and wet. So this kind of hypoperfused and congested. So this kind of patient, they have the more grave prognosis will be this cold and wet patients, and they are difficult to manage. Usually they have this concomitant cardiogenic shock with pulmonary edema. So you have to address both the diuresis as well as the inotrope support. So their management is kind of difficult, especially the cold and wet patients. So again, this is the pictorial presentation of what we have said. So we can classify based on their perfusion status and congestion status as warm, dry, warm, wet, cold and dry, and cold and wet. So basically this classification is used for the management purpose. So our management will be based on either the for one of the categories. So we'll choose appropriate management based on the classification of the patient. And the other famous classification is based on the patient's functional status. So this New York Heart Association classification of heart failure patients. So they are classified into 4 groups. The first one is NIHA class 1, which they have no limitation in physical activity, and ordinary physical activity like does not cause any symptoms of heart failure. And the other is NIHA class 2, where slight limitation on physical activity. They are comfortable at rest, but they have ordinary physical activity, and they have symptoms. And the class 3 one, the class 3, they have marked limitation on physical activity and comfortable at rest, but with less than ordinary activity. They have symptoms of heart failure. And the fourth one, those patients who have symptomatic at rest, they are categorized into class 4. So this is just again for the management purpose, and for the prognostication we classify based on their functional status into 4 categories. And the other the classification, we can classify based on the ejection fraction. And according to the updated guideline of European Society of Cardiology 2021 heart failure management, there are 3 categories of heart failure based on the ejection fraction. The first one is with reduced ejection fraction, where ejection fraction is less than or equal to 40%, which is previously known as systolic heart failure. And the second group are those mildly reduced, or previously called mid-range ejection fraction, but it's currently termed as mildly reduced ejection fraction, where the ejection fraction is between 41% to 49%. And third one is heart failure with preserved ejection fraction, where the ejection fraction is above 50%, and these are previously known as diastolic heart failure. So classifying patients based on their ejection fraction, it has relevant for one thing to select this long-term like medications and Also, it can tell us the cause of the heart failure. So we can classify, at least we can have a clue of the underlying pathophysiology based on the ejection fraction. So when we see the diagnosis of acute decompensated heart failure or acute heart failure in general, so mainly, as you know, heart failure, it is a clinical diagnostic. So based on sign and symptom and additional supportive evidence or investigations that we reach to the diagnosis. So there is no single sign or symptom that's highly predictive of heart failure. So in general, so we have this high probability, low intermediate probability, and low probability of acute heart failure diagnosis. So if the patient is prior history of heart failure, if the patient has prior history of heart failure and he presented with sign symptom of dyspnea or fluid retention, that is high probability, and patient with no prior history of heart failure presents with new onset of orthopnea, elevated JVP, or typical chest X-ray showing pulmonary edema. Again, based on that previously seen classification, these patients they have high probability of heart failure. And when you see the intermediate probability, those patients who have no prior history of heart failure, but known to have cardiac disease or those cardiac index events, if they have those events but no prior history of heart failure, and if they have uncertain JVP, or if you are not sure whether the JVP is raised or not, and no evidence of pulmonary edema, so in this kind of patient, you have to send BNP and pro-BNP, any terminal pro-BNP, you have to send in. If these two, either of these two are significantly elevated, and you will again reach to the diagnosis of heart failure. And those patients with who lacks evidence of cardiac disease, like normal ECG finding, normal echo finding, and who have a clear explanation of for symptoms of shortness of breath, like chronic lung disease or other like lung infections. If they have this clear additional explanation, so these patients can be categorized as low probability heart failure, even if they present with sign symptom of heart failure. So in general, we can classify based on high probability, intermediate probability, and low probability. So usually this the BNP and pro-BNP are saying for like intermediate probability and low probability patients. So when you see signs symptom of heart failure, usually patient is present with fatigueness, and they have shortness of breath at rest or at like at exertion. They have dyspnea, tachypnea, cough. They have diminished exercise capacity, orthopnea, pain, nocturia. They can have either weight gain or weight loss, and they can have edema or like extremity swelling, and increased abdominal gas, bloating, and abdominal pain, usually in the right side, just due to this congestive hepatopathy, and loss of appetite or early satiety. And from the history, the past, those like events like past history of heart failure, having cardiac disease, and systemic illness, tachypnea, and having like cold extremities and elevated JVP, distended neck veins. All these are signs and symptoms of heart failure. Having this gallop, like parasternal shift, usually that tells you the patient has this dilated cardiomyopathy, and having this ascites, like leg swelling and anasarca. All these are signs symptoms of heart failure. So this famous the Framingham criteria. So it's mainly used for population-based studies. So so they have these minor and major criteria. So what the major criteria are like having like PND neck distension, rails, cardiomegaly on chest X-ray, or acute pulmonary edema, accessory gallop, and increased venous pressure, increased having this hepatojugular reflex. These are all the major criteria, and minor criteria like ankle swelling, night cough, dyspnea on exertion, hepatomegaly, pleural effusion, increased in this vital capacity, so decreased in vital capacity in tachycardia. These are the minor criteria. So having like two major criteria, or like one major and two minor criteria was used as a diagnostic for heart failure. So still we can use this Framingham criteria, but currently it's getting outdated. So investigations regarding investigations, you can say in the CBC. So mainly you can see on CBC to see the like the CBC. On CBC, if you see infections for those precipitant factors, and or you can see the anemia as a precipitant factors, and urine analysis, again you can see like any presence of infection on the urine, albuminuria and urine casts. So you can see those things on the urine. Even you can check if the patient is a diabetic patient for the like ketoacidosis, and on if the patient has ketonuria, and on the electrolytes, especially patients with congested kind of heart failure, they have this dilutional hyponatremia, and due to the medication effects, they can have hypokalemia. So you have to send electrolytes again for this patient, and due to the spirulactone effects, they can have hypomagnesemia and like that. And you have to check the creatinine level, just and this the cardiorenal syndrome. So you have to check the creatinine again for either prerenal azotemia and cardiorenal syndromes, and you have to send liver function test, thyroid function test, and on chest X-ray you can see pulmonary venous congestion, cardiomegaly, and interstitial edema can be seen on the chest X-ray, but having normal chest X-ray doesn't rule out heart failure. So up to 20% can have a normal chest X-ray. So on chest X-ray, you can see different like evidence of pulmonary heart failure. Like you can see pleural effusion, and for example, on this X-ray, you can see that the vascular markings are prominent. So usually this tells you patient have pulmonary edema, and also this chest X-ray show you there is air bronchogram, and consolidations are seen on the chest X-ray, and so and especially down the right side also it is congested with alveolar pulmonary edema. So you can diagnose, and chest X-ray will guide you with the diagnosis of your heart failure. So you can see cardiomegaly and like that. So the other is the ECG. On ECG, ECG mainly we use ECG to see the underlying cause, or if there is precipitant or not. So signs of ischemia, for example, on this ECG you can see there is segment depressions on diffused kind of segment depression. So this tells you there is myocardial ischemia. And also you can diagnose like arrhythmias like atrial fibrillations, atrial flutter, ventricular tachycardia, and all those arrhythmias can be diagnosed with the ECG. So ECG is also a very important investigation modality. And the other is bedside ultrasound. So currently we are using right and left bedside ultrasound in the emergency. So you can detect even more early than auscultation in chest X-ray. You can detect pulmonary edema using bedside ultrasound by seeing these B lines. So as you know, these are the on the image. The white lines are the B lines. So they are up to 94% sensitive and 92% specific in detecting pulmonary edema. in patient with heart failure. So bedside ultrasound are very important in detecting heart failure and in detecting those precipitant factors as well. So those patients with greater than or 3 B lines, we consider B lines as significant if it is greater than or equal to 3. So if B lines are present, so you can directly go, it is like acute heart failure is likely. So again, with your bedside ultrasound, you can do bedside ejection fraction, and you can clearly diagnose heart failure. And the other is if the patient has no B line, then you are going to measure the IVCs or inferior vena cava diameter, and if it is greater than 2, with a variability of less than 50%, so you have to obtain BNP. So if the BNP is high, then that's high likely of heart failure. Or if the evidence of acute RV strain, then acute heart failure is again high likely. So based on bedside ultrasound using the algorithm, you can diagnose the heart failure. And other very important investigative modalities, echocardiography. So for patient with new heart failure or if you suspect there is change in cardiac function, you have to send echocardiography. So on echo, almost it tells us everything. So we can diagnose the ventricular size, regional and global systolic function, diastolic function, any valvular, if there is valvular disease, pericardial disease, and any right atrial pressure and pulmonary artery pressure, and we can diagnose all these things. And in detail, functional status of the heart will be obtained from the echocardiography. So echo is one of the very important diagnostic tool. And the other is the BNP and N-terminal pro-BNP. So this usually help us to does high sensitivity. So it usually help us to rule out heart failure, or if, for example, like when the cutoff value that we use for BNP is around 100 picogram per milliliter, and usually even on the new guidelines they take as low as 35 picogram per milliliter. So if this is less than that of the cutoff value, so you can safely say the patient has no heart failure. Otherwise, the different conditions like pulmonary hypertension, pulmonary embolism, pneumonia, sepsis, renal failure can elevate this BNP and N-terminal pro-BNP. So usually it has high negative predictive value than the diagnostic value, but still it is one of the important diagnostic tool that we use in the emergency department. So when we see the treatment, generally the initial approach is driven by the presentation of acute hemodynamic status and volume status of the patient. So in all critical patient, as you know, always airway comes first, so you have to secure the airway. So if the airway is not secured, and if the patient is not protecting and maintaining his breathing, you have to secure that. And supplemental oxygen can be given in different form, and especially for patients with pulmonary edema, non-invasive like CPAP and BiPAP have this huge impact and have mortality benefits. So you can use these non-invasive ventilations. And so we can see the management based on the patient's like blood pressure status, either for those hypertensive acute heart failure patient. The first line of management, other than the resuscitative measures that we see, or like the ABCD approach, is the vasodilators. So the first one is the nitroglycerin. So it is a short-acting, rapid onset, and systemic, venous, and arterial dilator. And it has also a coronary artery dilator effect. So this nitroglycerin has preload decrements, afterload decrement, and also it's increased the coronary artery blood flow. So it will augment the contractility as well. So it will decrease the mean arterial pressure by reducing the preload and afterload. So as I said, it has also coronary vasodilatory effect. So the initial approach, usually you can give sublingual nitroglycerin with 0.4 milligram, or you can use the spray dose or the tablet form. All are this available, and even it has the IV preparation. So you can use whatever option is available in your setting. So usually if you are giving IV nitroglycerin, you can start with 0.5 to 0.7 microgram per kg per minute in IV, and you can titrate every minute. So it is ultra short acting. So you have to keep in continuous infusion form, or you have to frequently administer nitroglycerin to sustain the effect. So you can go as high as 20 microgram per minute based on the patient tolerance of the blood pressure, and there's symptoms like it has flushing and this flushing kind of side effect. So the other is you can apply transdermal nitroglycerin. Usually only after the initial therapy has improved, so you can switch your route of administration to transdermal nitroglycerin. So if nitroglycerin is not working, so you can switch to nitroprusside. So it is potent. Vascular dilator. So it has both mainly it has arterial dilator effect. So if you are using nitroglycerin and the dose is above 200 microgram per minute, so you can switch to nitroprusside, and you can start with the initial dose of 0.3 microgram per kg per minute and titrate every 5 to 10 minutes to the maximum dose of 10 microgram per kg. And it has side effects like hypotension and cyanide toxicity, especially if you are using the higher dose and prolonged use, the side effect will be worsened. So, so because this is a potent venodilator and arterial dilator, it is contraindicated in patients with hypoperfusion and pre-existing hypotension. In this kind of patient, you are not supposed to use this nitroprusside. And the other is after you are using these venodilators, the second one is the loop diuretics. So once you are using the loop diuretics, you can use either furosemide, torsemide, or brutamide. Sorry. So if the patient is not using any diuresis prior, you can start using Lasix or furosemide 20 to 40 milligram. You can start with that, or if the patient is using already on PO form of like furosemide, you can use that total daily dose of the IV. So you can multiply that with 1 to 2.5 times to the patient previous dose, and you can give that as a form of bolus dose. And subsequently, you have to scale it every 2 hours. You have to check the patient, either the urine output or the patient weight, and you have to escalate the diuretics dose. So sign and symptom of heart failure with normal vital sign and oxygenation and ventilation. The second group are this normotensive patient with, so in this they have this normal vital sign. In this situation, the first line of management is diuresis. So because patients are congested, so again you have to use, unlike that of the hypertensive patient, we are not going to use these venodilators, rather we'll start from diuretics. So we'll provide rapid diuretics, will provide rapid congestion relief, will be from the diuretic effects, but none of the diuretics have mortality benefit. So just they have only have the symptomatic relief. So usually already we have discussed the dose. So if the patient is like de novo heart failure patient, you can start with if it is like furosemide that's available, you can use 20 to 40 milligram IV. If there is bumetanide is available, 1 milligram IV, and torsemide is available, 10 to 20 milligram IV can be used. Otherwise, as we have discussed, we can use 1 to 2.5 times the total daily dose of the patient can be given if the patient is already on the diuretics. And like bolus diuretics can be administered 2 or more times per day, but like researchers have shown there is no effect. So sometimes like physicians tend to use the continuous infusion form, or some of the physicians prefer the bolus dose. So this is the meta-analysis of that. Different RCTs were analyzed, and as their conclusion was there is no overall mortality difference whether you are using the bolus dose of diuretics or the continuous infusion form. So you can use whichever way you are preferred. So but usually if giving bolus dose, higher bolus dose will have this transient hypotensive effect. So if you are anticipating to use higher dose, it's better to use in continuous infusion form. So for those hypotensive heart failure patient, so the first one is to use so the first one is to use on general approach. If the patient is hypotensive, always you have to challenge the with fluid. So as fluid, you can give 2 bolus, like 250 ml of bolus dose can be given 2 times, total of 500. And if there is evidence of shock, you can use inotrope, and like vasopressors can be. Galaxy mute ብታደርግልህ so if there is evidence of shock, despite the fluid challenge, you can use inotropes and vasopressors. So usually what we like our practice is like we are using bedside ultrasound. So we'll assess the patient's IVC, and if the IVC is dilated above 2.5 centimeter, and if there is no variability after fluid challenge, so we'll directly give the patient vasopressor and inotrope support. Otherwise, if there is like room for fluid based on our bedside ultrasound assessment, so we'll still give the patient fluid. And once the IVC is dilated and the patient is, if the tank is full, after that we'll give this inotrope and vasopressor support. So the first inotrope is, so it is milirone. So it is phosphodiesterase inhibitor, and it has both it has myocardial inotropic effect by inhibiting degradation of cyclic AMP, and it reduce systemic and pulmonary vascular resistance. So its effect is on both the two circulations. So it improves left ventricular diastolic compliance. So the cardiac output will be increased. So patient usually with milirone will start with 50 microgram per kg over 10 minutes, and followed by the maintenance dose of 0.375 to maximum dose of 0.75. So usually milirone it's not available here. So but if it's available, it is one of the good medications that we can use in patients with hypotensive acute heart failure patient. And the other is dobutamine. So usually dopamine has beta-1 adrenergic receptor effect, with it has only minimal effect on beta-2 and alpha-1 receptors. So mainly it has this ionotropic effect, and it has slight peripheral vascular between the slightly decreased peripheral vascular resistance will be decreased by this dopamine. And usually we'll start with the dose of 2.5 microgram per kg, and we can titrate up to 20 microgram per kg. And the other is dopamine. So again, almost it has a similar effect with that of dopamine, but it has also effect on the dopamine receptor effects on usually on the renal and the mesenteric arteries. But currently we are not using dopamine for as a renal. There is no renal dose of dopamine currently, so we can start dopamine from 3 to 10 microgram per kg per minute, and we have to titrate up to like that of dopamine up to 20 microgram per kg per minute. And so it has both beta and alpha effects. And other vasopressor therapies are like norepinephrine. So currently norepinephrine is the first line of vasopressor that we use for all these shocks. Norepinephrine is the first line. So it has mainly a beta adrenergic effect. So it has potent, it is potent vasoconstrictor. So mainly it acts by increasing the afterload. And the other is the epinephrine. Epinephrine has alpha and non-selective beta adrenergic. So if norepinephrine is not available, so we have to use epinephrine. So epinephrine is the second line, and after that you can use like dopamine as the third line of vasopressor and ionotrope therapy. So this is what we have discussed, the dose. So dopamine you can use 2 to 5 microgram per kg per minute. Dopamine also 3 to 5. Norepinephrine 2 microgram per minute, and you have to titrate epinephrine from 0.5, sorry, from 0.1 to 0.5 microgram per kg per minute, and milirolin 0.5 microgram per kg per minute. So the other that the medication that we previously used was morphine. So morphine, it has decreased pulmonary congestion, it decreases heart rates, and also decrease blood pressure, cardiac contractility, and oxygen demand. But researchers have shown that morphine increase the mechanical ventilation. Patients with morphine, they have high chance of being intubated and put on mechanical ventilator. They have prolonged hospitalization, prolonged intensive care unit stay, and so they have high mortality in general. So currently we are not like advocating on the use of morphine in those patients with heart failure. That if you want to use morphine, you can use like the lower dose of like 2 to 4 milligram IV can be used for patient with heart failure. So to gain those effect of decreasing the pulmonary congestion and those that we have seen. The other medications are ACE inhibitors and angiotensin receptor blockers. So usually these have uh, mortality benefit, but not in the emergency stay, but in the long term for those chronic heart failure patient. ACE inhibitors and angiotensin receptors have mortality effects by blocking the activation of the RAS system, and by counteracting the angiotensin 2 effect. But using these drugs in the emergency setting has no effect. But as I've said, you can use in the long term. So drugs used to prevent progression of heart failure, like ACE inhibitors, angiotensin receptors, beta blockers, and aldosterone receptor antagonist, hydralazine, and ascorbyl dinitrate. All these drugs can be used in the chronic follow-up setting, not in the emergency setting. So, and just this is the chronic management of patients. So you can use based on the 2021 guidelines, so you can use ACE inhibitors, beta blockers, and like mineralocorticoid antagonist, and all these medications can be used, plus based on the patient ejection fraction, additional like intracardiac defibrillators can be implanted based on the patient ECG finding and ejection fraction. So yes, this is for you to read for as an assignment or as take-home message. You can read on patients with chronic management of chronic heart failure patient. So this is the reference that I used for this lecture. So if you have any question, you are welcome. So if you don't have any question, let me say a few things about CPD. So በአማርኛ እንዳወራ ይፈቀድልኝና ያው ሁላችሁም ስለ ሲፒዲ መታወቁ ይመስለኛል። ሶ ሲፒዲ ኦር ኮንቲኒየስ ፕሮፌሽናል ዴቨሎፕመንት ያው በቅርቡ በጣም ፌመስ እየሆነ የመጣ ኮንሴፕት ነው። ለዚህ ሁሉም ሰው ባለበት የሚሰራበት ቦታ ራሱን ማብቃት አለበት። ስለዚህ የምትሰሩት ነገር እያንዳንዱ ነገር ከረንትሊ ሲፒዲ አለው ማለት ነው። ስለዚህ የምታቀርቡት ፕሬዘንቴሽን እያንዳንዱ የምትወስዱት ስልጠና it's part of your continuous professional development። ስለዚህ ለእናንተ እንደ ግብዓት በመሆን የተሻለ ሐኪሞች የተሻለ የጤና ባለሙያዎች እንድትሆኑ የሚያግዛችሁ ነው ማለት ነው። ስለዚህ ሌላው ደግሞ ያው ከረንትሊ ላይሰንሳችሁ በሚታደስበት ጊዜ ሁሉም ሰው አትሊስት ይርሊ ማሟላት ያለበት የሲፒዲ ሃወር አለ ማለት ነው። ስለዚህ ያንን ሲፒዲ ሃወር ደግሞ የምታገኙት እንደዚህ የተለያዩ ስልጠናዎችን በመሳተፍ ራሳችሁን በማብቃት ነው ማለት ነው። ስለዚህ እንደ ብሉ ሄልዝ ኢትዮጵያ ከረንትሊ ያው ሲፒዲ ፕሮቫይደሮች ነን። የተለያዩ ስልጠናዎችን እያዘጋጀን ሲፒዲ ሰርቲፋይ እናደርጋለን። በዚያን ሰርቲፊኬት ይዛችሁ ጤና ጥበቃም ስትሄዱ ላይሰንሳችሁ with ሲፒዲ ነው ማለት ነው። ሁላችሁም እኛ ጋር መታችሁ ያሉትን የሲፒዲ ድሎች ተጠቃሚ እንድትሆኑ በዚህ አጋጣሚ ጥሬን አስተላልፋለሁ። ሲፒዲ ላይ የትኛውንም ጥያቄ ካላችሁ ኮሙኒኬት ማድረግ ትችላላችሁ። ብሉ ሄልዝም በብሉ ሄልዝ አድራሻም ፐርሰናል ኢሜል ላይም መጻፍ ትችላላችሁ ማለት ነው።
ይሰማል?
አዎ ይሰማል።
ኦኬ ሃይ አይ መጨረሻ ስላይዱ ላይ ሃርት ፌሊየር ሪዲዩስድ ኢጀክሽን ፍራክሽን ላላቸው ፔሸንቶች ክሮኒክ ማኔጅመንት ላይ የምንሰጣቸው ተብሎ የተጻፈ አንደኛው ዳፓ ነው እና ዳፓ ይሄ ኤስጂኤልቲ ለዲያቤቲክ ፔሸንቶች የምንሰጠው ዋን ኦፍ ዘ ኒው ድራግስ ነው አይደል? እና እሱ ዲያቤቲክ እና ዲያቤቲክ ለሆኑ ፔሸንቶችም ነው የሚሰጠው ወይስ ጀስት ዲያቤቲክ እና ሃርት ፌሊየር ላላቸው ክሮኒክ ማኔጅመንት ኦፍ ሪዲዩስድ ኢጀክሽን ፍራክሽን ላላቸው ሃርት ፌሊየር ፔሸንቶች ነው የሚሰጠው? ስላየሁት ነው ስላይዱ ላይ።
እሺ ይሰማል?
ይሰማል።
እሺ ያው እንዳልሽው ነው ዳፓ ዩዥዋሊ ነን ዳያቤቲክ ከሆኑ ብዙ ቤኔፊትም የለውም። ስለዚህ የምንጠቀመው ፎር ዶስ ፔሸንት ዊዝ ዳያቤቲክ ለሆኑ ፔሸንቶች ነው።
ኦኬ እሺ ቴንክ ዩ።
እንዴት አመሻችሁ? የኔ question is ሞርፊን ለምንድን ነው ለማኔጅመንት መጠቀም ማለት በሎወር ዶዝ ብቻ የተባለው ለምንድን ነው የቀረው መጠቀም?
እሺ መጠቀም እንትን ነው ቅድም ዲስከስ አደረገ ሜንሽን እንዳደረኩት ሞርፊን ላይ ጥናቶች እንደሚያሳዩት ዶስ ፔሸንትስ ሞርፊን የተጠቀሙ ፔሸንቶች they have higher mortality ያላቸው just due to the complication of morphine ማለት ነው። ኦኬ high mechanical ventilator requirement አላቸው፣ high ICU stay አላቸው። in general overall mortalityያቸው is high። ስለዚህ በዛ ምክንያት we know morphine effect vasodilator effect አለው የፔሸንቶቹን anxiety relieve ያደርግልናል blood pressure ይቀንስልናል all this effect that we need on the morphine but the other way ደግሞ this comparative studies እንደሚያሳዩት mortality ስለሚጨምር if it's necessary to use low dose higher dose morphine complications at the same time ስለሚጨምረው it's better to use the lower dose ማለት ነው 2 to 4 milligram morphine so you can get the effect of those already discuss ያደረግናቸው benefits you can get those effect at the same time lower dose morphine has less complication than higher dose ማለት ነው okay ስለዚህ like higher dose morphine respiratory depression እነዚህ አይነት effects ስላሉ patients tend to stay on mechanical ventilator for longer day ማለት ነው ስለዚህ longer day longer complication longer mortality ስለዚህ overall mortality at the same time ይጨምራል ማለት ነው okay
okay so morphine and መስጠት ማንችል ከሆነ what are the other options of opioids
so usually as I have said opioids like as not as an anti-pain አይደለም እንጠቀማቸው አይደል እዚህ ጋር ምንድነው especially previously patient with pulmonary edema first line vasodilator diuresis and the third line you can use morphine ተብሎ ነበር የሚታሰበው then the morphine effect አሁን ሜንሽን ያደረግናቸው because of those benefits morphine እንጠቀማለን ስለዚህ it's optional ማለት ነው አለመጠቀም ትችላለሽ or if you want to use morphine you can use lower dose morphine it's optional or if you have available you can use fentanyl so just ለምሳሌ fentanyl it is almost it has no cardiovascular effect alone it's one of the potent opioids if you want to use like opioid as a pure analgesic effect መጠቀም ከፈለሽ you can use fentanyl otherwise morphine effect ጥናቶች እንደሚያሳዩት already mention እንዳደረኩትም mortality ይጨምርብናል ማለት ነው ስለዚህ you can use other options like vasodilators diuretics and non-invasive CPAP መጠቀም እንችላለን ማለት ነው
thank you
እሺ ተጨማሪ ጥያቄዎች ካላችሁ አንድ ደቂቃ እንስጣችሁና ከሌላችሁ ደግሞ በእንደዚህ አይነት ፕሮግራሞችን በተለያዩ ቶፒኮች ላይ የተለያዩ እንግዶችን በመጥራት በዘርፉ ትልቅ እውቀት ያላቸው እንትኖች በመጥራት እንደዚህ አይነት ዌቢናሮችን ለማዘጋጀት አስበናል በየሳምንቱ በየሁለት ሳምንቱ ሆነ ያው በቻልንበት ጊዜ ማለት ነው እና ሶሻል ሚዲያ ላይ ይሄን ነገር እናሳውቃለን እንድትከታተሉ ጋብዛችኋለን ከዛም ደግሞ በተረፈ በዚህ ዌቢናር ላይ እስካሁን ባለው ሁኔታ ያላችሁ ኮሜንት ወይም የኔ አስተያየት ካላችሁ info@bluehealthethopia.com የሚባል ኢሜል አድሬሳችን ላይ ገብታችሁ ኮሜንት መስጠት ትችላላችሁ ማለት ነው ስለዚህ anyone መጨመር የሚፈልገው ነገር ካለ ወይም ደግሞ እንሰናባበት ለዛሬ
እሺ በጣም ነው የምናመሰግነው በጣም ደስ ብሎናል
እሺ እኛም በጣም እናመሰግናለን መልካም ምሽት ጋይስ